Assalamu alaikum. We're waiting on the signal to start from the organizers.
It's okay, Dr. Hussein. I think we can start.
Okay, very good. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum jami'an. Good evening, everyone. First of all, I would like to express my gratitude for you all coming and joining us at the late evening, if you wish, and joining us for this educational activity that's like truly not marketing. And we, of course, thank Bayer for sponsoring such an educational activity. We are a group of pulmonary hypertension practitioners at King Fahd Medical City who are actually trained and practicing with clinics in the field of pulmonary hypertension, somewhat rare disease, but we do have, alhamdulillah, enough experience and support that's present to support our patients and our referring physicians. The idea is to spread knowledge and awareness about the disease and start an open channel between us as practitioners and between you as potential referee and potential, champions in the future if you have interest in this field. Pulmonary hypertension is a wide field, as we will see in a minute, and there is potential that you will probably encounter a patient one way or another, and I'm sure you will have plenty of questions that we will answer during our presentation. The pulmonary circulation is a very nice and easy circulation that does not have a lot of muscles in it. It is very low pressure system, very low resistance system, and it accommodates the cardiac output in a very easy manner. And, some people might lose the whole lung and the other lung will accommodate the whole cardiac output without any issues. And this is the norm. This is what we expect that the pulmonary circulation will show. The pressures inside the pulmonary circulation is considered to be very low. The mean pressure in the pulmonary artery at large is 19 millimeter mercury. And of course, the resistance is considered to be very low, less than 1 Wood's unit or about 70 dynes. This is considered very low if you compare it to the systemic pressures where we deal with mean systolic pressure. Sometimes it reaches up to 130, 140, and in disease states, it's higher with mean pressures can sometimes reach 100. With our systemic vascular resistance can be in the thousands sometimes. So when we talk about pulmonary hypertension, as simple as the name states, pulmonary hypertension is elevation in the pulmonary artery pressure, where the mean pressure becomes more than 20. I showed you earlier that the upper limit of the normal is 19. And historically, if you have been keeping up with some literature before, the number above which that we can diagnose pulmonary hypertension was 25, but that was truly decreased, rightfully so, because above 20 is considered abnormal, and anytime we see a pressure above 20, that is considered to be elevation in the pressure. And now we have to have a little bit of an association of increase in the pulmonary vascular resistance, because if there is like increased flow, sometimes the pressure is high, but the pulmonary vasculature itself is healthy, and that does not meet the criteria for the diagnosis. We'll talk a little bit more about the diagnosis later this lecture and in a separate lecture. The pulmonary hypertension is it's not a disease. It is a hemodynamic state. It's the multiple diseases that are sharing some hemodynamic picture where the pulmonary artery pressure is elevated. That's why it's considered to be multifaceted disease. It can be seen by a primary care physician. It can be seen by cardiologist, can be seen by pulmonologist, rheumatologist, hepatologist, pediatrics that can be affected. So these patients, they have different diseases, different clinical phenotypes, but do they have similar like phenotypic pulmonary circulation, phenotypic clinical presentation when it comes down to the pulmonary hypertension itself? The disease is relatively new, and we are talking about 100 plus years of age. The first case report was back in 1891, and truly it was at the time description of a case of heart failure that does not fulfill all the regular criteria for heart failure. And after that, things were very smooth. I'm not sure if we have real older practitioners with us, but at one point, even when we went into medical schools, we knew about the pulmonary hypertension there is not much data available about the disease. Now, and this is a publication from 51 that was talking about case reports. Imagine we're talking about 3 case reports where this described their hemodynamic characterization. And that time, the hemodynamic story was relatively new. It started and people were excited about it. And these patients who fulfilled the clinical diagnosis of pulmonary hypertension, they did really have bad like hemodynamic profile with elevation in their pulmonary vascular resistance, elevation in their pulmonary artery pressure, as well as in the decrease in their cardiac index. They showed some pictures of the right ventricle, the right heart being dilated and hypertrophied, and they showed the pathology, and that's where the name became from. It was called pulmonary vascular sclerosis because they saw the pulmonary circulation being sclerotic, and they described the pictures as you see it. Few years later, there was a case series of 39 cases that fulfilled the clinical picture, and in that publication, they were warning that at that time, they called it the primary pulmonary hypertension, runs a malignant course, and it leads to right heart failure, and sometimes it leads to death. There is no treatment available, of course. We did not understand much of the disease back then. And they were calling in the same paper in 1954 that this diagnosis should be suspected. And it should be made not by a process of elimination, yet you have to think of it in an active way where you will establish the syndrome of which the pathophysiological process can be evaluated in the cardiopulmonary lab. So at that time, we have diagnostic tools to establish the disease. So start thinking actively about it. It's not a diagnosis of exclusion after ruling out everything else, similar to what we normally as physicians think whenever we encounter something unusual or difficult to diagnose. So that was an early call to start thinking of the disease as part of the differential diagnosis. At that time, there was means to diagnose, but there is nothing else known about the natural history of the disease or about the treatment options that they have. This is showing you the historical aspect of the disease as it progressed. In 1973, there were some outbreak of pulmonary hypertension in Europe that was called for attention, and people were worried about it. WHO were involved, and there was a meeting, and the decision was to start looking into this disease in a more probably scientific way, start looking for the cases, start studying them. Still, the story was slow, and they decided to do in the USA in the 80s a registry to collect these cases, try to study their natural history. Again, we are describing what is going on with them. And in 87 or so, they published their data showing that a few hundred cases were identified. And it turned out that we now a little bit know about the disease that affects women, that affects relatively younger people. And the presentation is right-sided heart failure that is not explained by a left-sided pathology. And again, the work has been progressing, and over the last few years, truly in the last, let's say 25 to 30 years, a lot of work has been accomplished because now we have so many lines of therapy to treat this disease, and we are diagnosing more and more of pulmonary hypertension that we were wondering what were these people doing before the diagnosis was established. A lot of them were missed. A lot of them were just having unfortunate death probably, or a poor outcome without understanding why. And in 1996, the first time ever a treatment became available for this disease. So for all of us sitting in this chat room and attending this lecture, this is something that we can relate to. I'm not sure if anybody was born after 96, but we are talking about very short period of time during which the disease has been very well characterized. There is multiple lines of therapy, and this is something that shows the science unraveling in front of our eyes. And still, we are accumulating new knowledge every day, new research, and we are still looking at more therapeutics that can help our patients. After the approval of the drug, there was a meeting, we said, in 1973, and they called it the World Symposium for Pulmonary Hypertension. A second meeting was held in 1998, and they decided at that time to start meeting every 5 years, where they review all the scientific data and all the publications about the disease. And of course, people were more interested, pharmaceutical companies were more actively involved, and a lot of other research that took place, and more elucidation of the pathobiology about the treatment options and the best way to approach these patients. 5 years later, there is another meeting, in 98, this is 2003, 2008, that was in the US, and 2013, This was in Nice, France, and lately, that's the last one, in Nice again in 2018. We were lucky group of practitioners in Saudi Arabia, amongst whom the speakers for tonight were attending at least the last 2 or 3 meetings, and we were involved in the pulmonary hypertension from the beginning, and we have very well connections with the outside world about the disease progression and the impact that we can have on helping the patients with pulmonary hypertension. In '98, they decided to classify the disease into 5 groups. The terminology has changed. I don't want you to worry much about it, but the pulmonary hypertension that we are interested in and we talk about, pulmonary hypertension due to left heart disease, pulmonary hypertension due to lung disease, pulmonary hypertension due to chronic thromboemboli, and miscellaneous group of patients that was grouped under group 5. So these are the 5 groups, and this is the latest guidelines that was published a couple of months ago, that's based on the 2018 publication or meeting, and of course a lot of other meetings, publications that happened afterwards. But this is the most current classification of the disease, and they classified it into idiopathic. This is the interested one. The group 1 is the one that we are very much interested in, but all of them are called pulmonary hypertension. We'll classify them in a minute now. The importance of idiopathic, that we don't know why does it happen, and these are the classical prototypic agents. Some of them might have a family history, heritable we call it, and some of them are associated with other factors, one of which is drugs and toxins, drug addicts, methamphetamines. Some of the chemotherapeutic agents might be associated with pulmonary hypertension, and of course multiple other medical conditions that we commonly see in our practice that might be associated with pulmonary hypertension. And probably now it becomes more clear why I said this disease is multifaceted, multi-specialty. All of them, they end up with pulmonary hypertension, and some of them, of course, that will share the same clinical and hemodynamic profile when it comes down to the end of the spectrum. HIV infection is associated, pulmonary liver patients are associated, some congenital heart diseases that are associated with shunt that does not belong to the heart failure, but they are congenital heart diseases that can be associated with pulmonary hypertension. In our country, it's not an issue, but in Egypt, in Brazil, schistosomiasis is another well-identified infectious disease that is associated with pulmonary hypertension. Of course, if you are in the pediatric ward and you know about the persistence pulmonary hypertension in the newborn, because during the first breath, what happens, all the capillaries of the pulmonary circulation will open up, the resistance will go significantly down, and the pressures will become very low. The blood will be diverted. Usually it was going to the systemic circulation, but now the lung is ready and the circulation, it can adapt. Sometimes this process is not normal. It might take some time to pick up, and the people will have persistent pulmonary hypertension of the newborn. And there is an entity called PVOD. I will mention it later on. The group 2 is because of heart failure. It's a pulmonary venous hypertension. It has its characterization, and this is the most common cause of pulmonary hypertension. So if you think about pulmonary hypertension, it is estimated that 1 in each 100 on the globe have pulmonary hypertension, but the pulmonary arterial hypertension is somewhat rare. Now, when you start looking into the heart failure, looking into end-stage lung diseases, that's very common to be associated with pulmonary hypertension, but these are not the prototypic PH patients that we talk about, and usually we do not offer them pulmonary vasodilator therapies that we normally treat pulmonary hypertension with. The group 4 is another interesting group because it is similar to group 1. It's unique. I'll show you some pictures about it as well, and it is because of recurrent pulmonary emboli into the pulmonary circulation, where enough occlusion of the circulation will lead to increase in the resistance, and they present exactly the same as pulmonary arterial hypertension, yet they do have a reason for this pressure. The treatment is somewhat different. A lot of them, they can be somewhat cured by surgical interventions, and some of them, they will require medications similar to the ones that we treat pulmonary arterial hypertension. Group 5 is the leftovers, if you wish. We have a lot of diseases like metabolic disorders, hematological disorders, sometimes there is immune diseases that can be associated with pulmonary hypertension. They don't have a very well characterization. Still, they are grouped together because their clinical features is not exactly the same as the group that we will be talking about all through this meeting, so that they put it in group 5, and still more studies are needed to characterize them more, including their therapy. So in summary, this is what I mentioned earlier, that there are 5 groups. the idiopathic and heritable, and that's the group 1. That is the prototype. If you see down there, it is rare. It's considered a rare disease, unlike the heart failure association. It's considered very common in patients with severe PH, non-severe PH, and severe PH related to lung diseases, whether it is interstitial lung disease, advanced COPD, sometimes hypoxia for whatever reason. In pediatric age group, there are some developmental abnormalities. It is somewhat common. CTEPH is rare because it does not, PEs are common, but not every patient who has PE will end up having pulmonary hypertension. Roughly speaking, we talk about 4% of these people might end up having elevation in the pressure, and of course, rare again, the other rarer diseases. And we will be talking about all of this. Now, the group is joined together because of their clinical presentation. The presentation is the presentation of elevation in the pulmonary vascular resistance and elevation in the pulmonary pressure with its reflection on the right ventricle. Some pathological findings are supportive. When they looked into autopsies and case patients with pulmonary hypertension, they looked into similar pathological findings. Of course, the hemodynamic definition is what grouped them together. And currently, most of these cases are treated about the same. The approach to treatment is similar among all these groups of patients. Before, let's say 2 months ago, the definition was still pH above 25 to diagnose it. They were giving this arbitrary when they decided to label the disease. They said, let's give room above 19, and they selected 25, but it was not very scientific. And of course, that to call it pulmonary hypertension, but to call it pulmonary arterial hypertension, we have to be sure that this is not because of a left heart disease, so the wedge pressure should be normal. We have to be sure that the pressure is elevated above 25, and the PVR, it used to be above 3, but now has changed to being above 2. Now, things are moving more towards more scientific definition because availability of resources, availability of diagnostic tools, and effective treatment options are available. So they said, let's pick up on these patients early and see if we can make a difference earlier than the usual. So this is the current state of the definition. pH is when the pressure above 20, pre-capillary when the pressure is above 20 with a wedge of less than 15, and a PVR of more than 2 wedge unit. In the cardiac cases, sometimes you do have increase in the wedge pressure, but sometimes it's associated with increase in the PVR. So that's another unique group among the patients who are post-capillary, we call them. And now they are introducing a concept of exercise pulmonary hypertension. I don't think we will be able to see much of this, at least in our general practice. It might be there, but still the data is not very supportive, and definitely it will be somewhat rare to diagnose patients who develop pulmonary hypertension only during exercise. That has been always talked about, but the characterization and definition is still somewhat vague. This is what we mean by pre-capillary and post-capillary. It's very important to understand that anything that before it gets to the like the capillaries, before the capillaries, that's pre-capillary. It's not only in pulmonary arterial hypertension. It can be present in patients who have CTEPH, chronic thromboembolic pulmonary hypertension, and it can be present in patients with lung disease. So whenever we see a pre-capillary pH, meaning that there is elevation in the pressure with normal wedge pressure, we start thinking, is this consistent with a common lung disease? Is the patient having significant lung disease that might be causing this? If it's not, we always would like to rule out CTEPH because it's a unique group. Now, let's make sure that this patient did not have recurrent thromboemboli, because about 30% of these patients, they never report developing DVT or pulmonary embolism. And post-capillary, of course, that means the problem is usually in the left side, whether associated with remodeling of the pulmonary vasculature or not. And this is just summary of the hemodynamic part of the disease. This is a picture of a patient. I showed you earlier a picture of a normal pulmonary circulation or pulmonary artery. This is a pulmonary artery of a patient of mine who died with pulmonary hypertension, and at autopsy, this is what was in her lung. These are like plexiform lesions, the pulmonary circulation almost occluded, and this will cause the patient to have significant elevation in the pulmonary vascular resistance and the pressure, and of course, right ventricular failure. Patient died with sudden right ventricular failure, and this was her pathology. This is another patient who was kind of similar story. It's a male who has pulmonary hypertension, and he did have biopsy for another reason, and it showed almost occlusion of the pulmonary circulation with the blood vessels being infiltrated, and like, the endothelium is not healthy, just causing you to have, like, you wonder why is this patient is having these symptoms and this disease. So if you notice, pulmonary hypertension, it's not similar to the systemic hypertension. It's not a blood vessel tone only. In the systemic hypertension, the tone is elevated, the tension is high, and the pressure will go up. In this disease, we are talking about remodeling of the blood vessel, infiltration with inflammatory cells. There is fibrosis, there is subintimal fibrosis, and of course, the chronicity of this will lead to the problem. So it is not only a vasodilator state, it is really a truly pathological state that patients will be having and suffering from. And consequently, this will eventually lead to symptoms. The symptoms will be right-sided failure. And of course, later on, if it's not treated and diagnosed, it will lead to decline in the cardiac output. And this will be associated with a florid picture of right ventricular failure. Sometimes it might be quick, and sometimes it might take a little bit longer. As the disease progresses, of course, there will be more occlusion of the blood vessels, and the PVR and the pulmonary pressures will go higher. How do we tell these patients? They have non-specific presentation. Now, like, they have very similar to any respiratory disease patients who are coming with dyspnea, and this is the most common cause. Again, all the symptoms can be related back into right ventricular failure, and if it's early on, it might be like really you have to exert yourself like significant amount before you develop dyspnea. But sometimes in advanced cases, patients can be really functional class 4 and cannot walk to the bathroom. The decreased cardiac output features is, again, causing them to be fatigued, unable to do much, lightheadedness. Sometimes they get frank syncope because the cardiac output is unable to increase to meet the demand, and of course with consequences of lower extremity edema, sometimes ascites, and some occasional cough and hemoptysis is associated. So the common ones are dyspnea, fatigue, like when bending forward. This is a classic. Our patients, when they go pray, they can barely put their خلال السجود, they cannot make sujood. So they usually pray with their bed, because as they go down, the pressures will go up, and that acutely can cause significant symptoms. Sometimes it's even associated with syncope. Palpitation is not uncommon. Hemoptysis is rare, but it is significant. We get worried whenever we see it. And of course, sometimes it can lead to weight gain because of the edema, and like I mentioned, syncope. Signs, I would say, if you can suspect signs of pulmonary hypertension on a physical exam, that means the patient is really advanced. Early on, the patient might be easily missed. The features are subtle, a little bit maybe accentuation of the second heart sound. But with like progression of the disease, you will see that there is a right ventricular heave. You will see peripheral edema, ascites, JVP will be very high. Maybe they are going to be cyanotic because of the decrease in the cardiac output. Very rarely we see digital clubbing, and whenever we see it, we think of either lung disease associated, or we think of pulmonary veno-occlusive disease, as I mentioned before. And of course, sometimes we look for other features of other diseases, as I mentioned, whether it's DVT, PE, you start thinking of liver disease or connective tissue disease features that might help elucidate the clinical picture of the patient. How do they present? Similar to the heart failure classification, they might be symptomatic only with significant exertion all the way. This is functional class 1. Functional class 4, they really can do nothing. They are bed-bound or wheelchair-bound, and they cannot do any activity without having significant shortness of breath. The common question that we sometimes face, I mentioned, the patients are usually young. They are in their 20s and 30s, maybe up to 40s. In the West, they are diagnosing older patients, but that's a debatable group of patients with comorbidities. But the classical ones, they are young females. Usually they are in their prime time. They just got married. They might have 1 or 2 children. And some of them, we diagnose them at an earlier phase, and they're 16, 17 years of age. Sometimes they are engaged to be married, and we diagnose them, and they look at you, why me? Why do I have this bad disease? And of course, in the last 20, 25 years, science has been looking into it. And one of the associations that was clearly established is a genetic association in the gene of BMPR2. That defect can lead to significantly heritable disease that is very aggressive. It affects younger people, and usually it has a poor prognosis. The number of people affected by this is about 20% of the patients with pulmonary hypertension. They do have this, and this will lead to loss of the apoptotic function of the cell, and this will lead to uncontrolled proliferation, and eventually there will be occlusion of the pulmonary vasculature, as I said, in the endothelial side. Some people might look into this disease as a quasi-malignancy disease, where a progenitor cells that come from the bone marrow, that they will replace the cells at the time of their death. And these cells are having a very unique, unusual ability to transform into endothelial cells that are not amenable to apoptosis. That means they will proliferate similar to the cancer cells without programmed cell death. And this is another very common mechanism. Some people, they really make the association and comparison between pulmonary hypertension and oncology. Of course, completely different diseases, but the thinking about the cellular level might be the same. It was discovered that there is a molecule called endothelin, and this endothelin is a very toxic. It has a capacity to cause vascular constriction, and sometimes even pre-tumorous that can be really bad. And these patients might have too much expression of the receptors for endothelin, or the endothelin levels are high. And the earlier studies showed that the PH patients have higher endothelin, and in their pathology they do have higher expression of the endothelin receptors, and they identified these ET receptors. And one of the major mechanisms to treat this disease is trying to block this mechanism, and it is a somewhat effective way of treating the disease. Now we start thinking about the other mechanisms. Now, if you think about the heart failure, why would heart failure patients start having pulmonary hypertension? We said partly it's a flow, and partly it is remodeling of the vasculature due to the chronicity of the shunting. There's more flow into the left side. The left side is affected. That might stimulate proliferation and apoptosis resistance, and it will lead to the development of pulmonary hypertension, because not everybody will develop it, but significant amount of patients will develop it. We mentioned the PVOD, pulmonary veno-occlusive disease. In reality, it's a different disease, but it presents the same as pulmonary arterial hypertension. Lately, we discovered that the pathology is unique. They have, at the capillary level, there will be proliferation. And lately, they discovered that there is a genetic predisposition that puts the patient into the risk of developing this disease. And it is very common that we send this gene to diagnose patients with PVOD. Their response to therapy is unique, but the problem is that they don't respond as usual, but we don't have any other options but to treat them the way we treat pulmonary hypertension. And then they start having pulmonary edema, because the problem is at the capillary level. And that's when we say, this might be PVOD. Of course, they have other features, might be consistent with PVOD. I mentioned digital clubbing. We look into their CT scan. There might be some changes on their radiology as well. And if we do bronchoalveolar lavage, we see some cellular changes that are consistent with PVOD. Biopsy is the ultimate, but we do not recommend doing biopsy on these patients. The ultimate treatment for them is lung transplant, and they do very fine after lung transplant. I have two patients with PVOD. Both are young, below 18 years of age. Unfortunately, she died in our hospital because she was not eligible for any referral for transplantation. And the other patient was lucky enough to get transplanted in the States, and he is doing so beautiful. That was many years back. We mentioned how to think about this disease. We said there are some directly or definite association with medications. Aminorex is one of the important ones to know about, because the story started back in the 80s and late 70s with the diet pills that was associated with pulmonary hypertension. People were trying to lose weight since ever. And one of the way to go with fen, if you remember, if you've heard the fenfluramine, that was very toxic. And people were really developing pulmonary hypertension. I've seen it in the States. Lawyers were looking after patients who used fen so that they can sue the pharmaceutical companies. And there are other medications that can possibly associated with development of pulmonary hypertension. Just a list is there to keep in mind. How am I going to suspect this pulmonary hypertension? If the patients are using these medications and they have symptoms, think of it. In the States, about 28% in one study showed that these patients might be associated with amphetamine abuse, drug abuse, cocaine, amphetamine. Unfortunately, in our part of the world, I have seen a couple of cases with captagon. Again, similar idea, because these are very toxic to the pulmonary circulation, and it can cause pulmonary hypertension. Awareness about this and knowledge, I think it will be making detection a little bit earlier, and establishing the connection is earlier. Connective tissue disease is not an uncommon group of patients to develop it. Scleroderma is very common. Mixed connective tissue disease, some SLE, like SLE has a unique feature, but SLE patients, scleroderma, they might be associated with pulmonary hypertension. In a quarter of this is from Reveal registry. So keep an eye, any patients who have long-standing connective tissue disease and they start having symptoms, they might develop pulmonary hypertension. And if they do so, their prognosis becomes very, very significantly reduced. This is the survival of patients with scleroderma. Once they develop pulmonary hypertension, they are really bad, aggressive disease that can lead to death very quickly. Liver patients, it depends if you are working and seeing a lot of cirrhotic patients who are probably worked up for liver transplantation, you suspect to see pulmonary hypertension. Of course, the importance is that pulmonary hypertension is a contraindication for liver transplant. We need to detect them so that we will stratify them. And of course, suspect them at early stage where treatment sometimes can make a difference with them. They can even transfer their situation from inoperable to operable. Luckily, alhamdulillah, we don't have an HIV major problem in Saudi Arabia. Hopefully, it will continue to be the case, but HIV infection is associated with development of pulmonary hypertension. So far, the group 2 and the group 3, the lung and heart diseases causing elevation in the pulmonary pressure, is the number 1 and 2 causes of pulmonary hypertension. Still, the pulmonary arterial hypertension group 1 and the group 4 CTEPH that we are concerned with is considered to be somewhat rare. It represents only 4 to 5% of all the cases of pulmonary hypertension. We talked about the CTEPH. And in CTEPH, these chronicity, if you look into the image above, we see changes in the vasculature, not similar to what we see in acute pulmonary embolism. We tend to see this picture only in patients who had PE before, and the resolution of the PE was incomplete. Now, when we look into the VQ scan, a modality that's not very available in all the centers, but you see decrease in the perfusion into the lung, and this is very obvious, and it has to be significant, at least 2 large segmental defects to start suspecting pulmonary hypertension. And if you do angioscopy, you will see the pulmonary vessel is completely occluded because of the fibrotic material that gets there. The treatment number 1, or the first option, the treatment is surgical. It's a big surgery that's done at King Faisal Hospital. And sometimes we send the patients to the States where they will dissect the pulmonary artery and take the clot out. And this is what comes out of the surgical. So it's not a clot. It's really fibrotic material that is causing the occlusion. So if you wanted to understand what happens, is that there is a patient who have some predisposition, whether genetic or some exposure to risk factors, that will lead to vascular injury. And this vascular injury will lead to inflammation, endothelial dysfunction, and eventually it will be associated with pathological changes in the pulmonary vessels, progression of the disease where it will affect the right ventricular function, and the patient will die. Patients die is very unfortunate. Young people who like in their prime life, and we have a disease that does not really make a difference with them. The red line is the historical, without any therapy. With the available medications, things are getting better, but still there is room to doing more, because if we detect them early, things will change. Different diseases have different prognosis. Congenital heart disease tend to do very well, unlike the patients who have connective tissue disease or HIV, they tend to do worse. We know the functional status at diagnosis makes a difference in their long-term survival. In the lower curve, it is functional class 4, meaning that the patient just presented with florid right heart failure, and this is something that we don't like to see. Unfortunately, we still see it. We admitted a month ago a patient young, he's 24 years old with a functional class 4 pulmonary hypertension, and he was almost died. These people not tend to do well, but if we discover them earlier, we think that things will make a difference. From the classical studies that were done in the 80s, it takes about 2 years to diagnose pulmonary hypertension. By the time the patient presents to the doctor thinking about it, and of course, reaching into the proper diagnostic workup and treatment. This was back in the 80s. This is in the year 2008 and 9 in Australia. There's a better healthcare system, and the patients still, they have delay in their presentation. They usually see multiple physicians, primary care, before they establish the diagnosis. When we ask them back, when you start having symptoms and tracking back, well, I have seen a primary care twice or 3 times, then they referred me to a pulmonologist. The pulmonologist did some testing. He did not know exactly what's going on, and then they decided to refer to a specialist. This takes time, and the systems there are very strict in the time-wise. Now we wanted to break the cycle. The reason for our activity tonight is to make people more aware so that they can at least think of it. Think of it. If you are in doubt, if you're suspected, just refer to us and we will be very happy to see you. This is a very good representative case about what I said, that I was working on call in the ICU, and one of the ER staff nurses asked me, will you, doctor, see this ECG for this patient? I don't want to talk much about the diagnostic workup, but this is a very bad looking ECG for a patient with right ventricular syndrome, if you wish. There is hypertrophy, there is evidence of ischemia, and I saw the nurse immediately. We looked into her imaging. Her X-ray was this. It's a clear lungs. The heart size is large. She was in her 30s, married with 1 child. And of course, this is very abnormal X-ray. It turned out that she had a couple of previous X-rays that were missed. This was about a year ago. She came to the emergency room with a little bit of shortness of breath. X-ray was dismissed. She's a healthcare worker. She did not make much of it, and the people who saw her, they just dismissed her symptoms. And this was upon her employment about 4 years before that X-ray. Again, this X-ray was passed as normal. Probably so, but again, there is something abnormal in the hilum of the patient, and it progressed over the years. This is her echo, the echo showing, and the left side of the echo here on the left screen. This is the right side. Usually the right side is very small. We barely see it, but here it's very dominant, very enlarged, and affecting the left side as well. And there's a D-shaped septum. If you look into the right side of the image, this is a D-shaped septum. The right side, the pressure is encroaching into the left side and causing even further left-sided dysfunction. Pulmonary artery pressure estimation was in 64 by an echo. This is considered to be very high. Now we said 35 probably by an echo is a number above which that you have to be worried. We did some workup for her. She did not have pulmonary embolism or evidence of CTEPH, but very large right ventricle on the CT scan. And she had the classical pruning. If you've heard the word pruning about the vessels, if you see the vessel, it is a little bit like fat, or if it's bulky, and suddenly it starts tapering off. Very obvious on this particular image where you see the pruning of the blood vessels. VQ scan was negative. She never had a PE, and we eventually did a right heart cath for her, confirming the diagnosis of pulmonary hypertension. Patient still alive. That was a few years ago, alhamdulillah, with the proper therapy. But this is the case that usually patients present with. Now I'm going to stop here, and I will give the floor for my colleague. Now we will have a little bit of Q&A at the end of the program. Dr. Abdullah Al-Khudair, he's like a cardiologist at King Fahd Medical City. He is specialized in pulmonary hypertension as well as interventional cardiology, and he will take us through the journey of diagnosing pulmonary hypertension. Dr. Abdullah.
Thank you very much, Dr. Hassan. Excellent talk. Let me just open my slides. For the organizers, please, if I can be a host, so I can open my slides. I'm sharing screen now. You should see it. Excellent.
Yeah, we can see it.
Dr. Hassan really did a great job at giving an introduction about pulmonary hypertension. And he actually made my life easier because lots of what I'm going to talk about has been already addressed. So the things that I'll be talking about today is basics of echo, rest of other imaging modalities and pH, what labs should we order, and finally we'll touch base on the role of right heart catheterization. So of course, you're going into investigations after you've seen a patient and you've had enough pretest probability to make you think of the diagnosis of interest, which is pulmonary hypertension. So those are the symptoms and physical exam findings that Dr. Hussam already mentioned. Next is usually the first screening tool is the echocardiogram. And the echo basically is a test whereby an ultrasound beam is transmitted into the body and then it gets reflected by different tissues. And this reflection is basically happening at different frequencies. So the difference in frequency from the different tissue planes will give you the characteristic or pictures of the echocardiogram. So that's basically the basic principle of echocardiogram. So if you're sending too many pulses, you can have a live image, and that's what we see when we do the echocardiogram. We see an image that is moving. Unfortunately, this one is static, but basically it shows you the different chambers of the heart, and you can tell about lots of findings of pulmonary hypertension. So things like right ventricular hypertrophy or dilatation. You can assess the right atrial size. You can look at pericardial effusion as well. So this is the first part of the echocardiogram. Then next we do something called Doppler echocardiography. And basically the concept of Doppler states that if you're like, it's a method for detecting a direction of a velocity of a moving object. So the moving object here in the heart is basically the traveling RBCs, or the red blood cells, or the blood basically. So if you're sending a frequency to those moving RBCs, and this frequency is reflected back, you can estimate the speed of those RBCs. And if we estimate the speed, there is a mathematical equation whereby we can transfer or transform the speed into pressure based on something called Bernoulli equation. Again, it's not the idea of this presentation to go over the basic or the details of this, but the whole idea is that echo can detect speed of moving RBCs, and then we infer the pressure based on this information. So whenever you assume things and you do equations and things like that, the end result is not going to be very precise. And that's why echo is only used as a screening mode. It's not as a screening method. It's not the final diagnostic method, because there's lots of points where echo can be misleading. This is a picture of a tricuspid regurg Doppler. So basically what you're seeing, the envelope that you're seeing down there has a speed of, if you can see at the right bottom here, it's a speed of 2.5 meters per second. So this means the tricuspid regurg, the RBCs that are leaking, that are being leaked into the RA, are traveling at a speed of 3.8 meters per second. So you do the equation, and then you get a pressure gradient of 32 millimeter mercury. So that's the whole idea of echo. You can infer the pulmonary pressure by estimating the speed of traveling RBCs through the orifice of tricuspid regurg. You can see the idea of this picture here is that depending on the gain that you're sitting on your echo machine, you can be fooled by how much envelope you're seeing. And that's, again, one of the reasons why echo should only be used as a screening method rather than a final diagnostic method. So in the new guidelines, they have a long list of things that we should look at in an echocardiogram of someone who's suspected to have pulmonary hypertension. And again, I'm not going to bother you with all of these details, but just to tell you that echo is not just a number of RVs or right ventricular systolic pressure, but rather it is more of a holistic assessment of the pulmonary pressure, the right ventricle, right atrium, pericardial flow, pericardial effusion, amongst other things. Moving on, after echo, So we just said that echo is excellent as a screening tool. It is non-invasive, it's reproducible, it is associated with high negative predictive value for the condition of interest, and it's also cost effective. It will give us estimation of the RVSP, and that's basically pulmonary pressure. We know that the right ventricular systolic pressure is the same as pulmonary artery systolic pressure in the absence of pulmonary stenosis. So that's why we use the term RVSP. It's basically the same as pulmonary pressure if you don't have a pulmonary stenosis, which most people don't. We can assess and estimate the RV size and function. We can also look for additional causes for pulmonary hypertension, like congenital heart disease. And next modality in our diagnostic workup is the ECG. And basically, what you can see in this particular ECG, you have a sinus rhythm, you have a right axis deviation, you have a tall P wave and lead 2. You have an evidence of right ventricular hypertrophy based on a tall R wave and lead V1. So this ECG is very concerning for someone with increased right-sided pressure. Next, you do an X-ray, and in the X-ray, usually what you see is, like Dr. Hassam mentioned, the peripheral hypovascularity or pruning of the vessels. So another thing is the dilation of the pulmonary artery. You can see it here. This pulmonary artery is big, and this is a differential. There's a differential diagnosis for hilar fullness, or one of them is pulmonary hypertension. If you look at the lateral chest X-ray, you can see an evidence of RV enlargement as well. The chest X-ray will also help us in terms of ruling in or out signs of left heart disease or pulmonary edema, and also signs of lung diseases as well. And both can cause pulmonary hypertension, as we mentioned, as we saw, group 2 and group 3. Next, we do a pulmonary function test and arterial blood gases. And the reason for this is we want to detect if there is any pulmonary diseases that are causing impairment of the pulmonary function. It will help us distinguish between different pH groups. It will also assess comorbidities and also the need for supplemental oxygen. And we can also determine disease severity if we look at DLCO, for example. A very important diagnostic step in the journey of patients with pulmonary hypertension is to do a ventilation perfusion scan, or VQ scan. And the reason is we want to rule out group 4 or CTEPH, chronic thromboembolic pulmonary hypertension, which has a somewhat of a different treatment strategy. So if you see in this picture here, the left is normal and the right one is a patient with CTEPH. And you can see that this perfusion is, in the left, is homogeneous, involving all lobes of the lungs, while on the right-hand side, you can see it's patchy. There are areas that are more perfused than others, and this tells you there is some sort of a blockage or narrowing that is causing this perfusion defects. Another imaging modality that is essential for patients who are suspected to have a pulmonary hypertension is CT chest. And what we can get from the CT chest is a lot of things, but one of the most important things is how dilated the pulmonary artery is compared to the aorta. So if it is almost as big as the aorta, then you know that there is an abnormality causing the pulmonary artery to become dilated, and usually this is pulmonary hypertension. CT chest will also help us look at features of parenchymal lung diseases, and also if you give contrast, then we can look at findings of CTEPH as well, or sometimes you can also detect congenital heart diseases, so ASD, VSD, things like that. Next, we order a battery of blood tests and immunology. So basic blood work, including CPC, renal function, uric acids, liver enzymes, iron status are just basic blood work. BNP or pro-BNP is very important because it has a lot of prognostic value in patients with pulmonary hypertension. You also want to complete your workup and get in based on the patient characteristics and story, some serology for hepatitis and HIV, in addition to basic screening of immunological condition like rheumatological condition or connective tissue diseases. So we have someone who has evidence of pulmonary hypertension based on echo, and the question is, why do we still need a right heart catheterization? The goal of this lecture is to let you know that echo is just a screening tool, but the definitive diagnosis is right heart catheterization. Multiple reasons for this. One of them is I just show you some examples of how the echo can be inaccurate. Other thing is, on echo, we don't usually have accurate estimation of pulmonary vascular resistance and cardiac output, although we can, but it's not very accurate. And we know that PVR and cardiac output also have some important prognostic information. On echo, our ability to assess the filling pressures of the left side is also limited. And also we know that echo will not give us clear estimation of the RV function like the right heart cath does with the cardiac output. So those are some of the reasons why we need the right heart. So basically what right heart cath is a procedure done by a Swan-Ganz catheter that has the ability to measure pressure and also assess the saturation at different chambers of the heart. So basically what you do is you go through different venous accesses, most commonly that are used now as brachial vein or jugular vein or femoral vein. And then you basically measure the pressure in the right atrium, right ventricle, pulmonary artery, and finally the pulmonary artery wedge pressure, which is a reflection of the left atrial pressure. Right heart cath is it's not very difficult procedure to do, but it has a lot of technical points and tricks that need to be met in order to get the accurate information. Otherwise, it will give us information that are not very accurate, and this probably will raise more questions than answers. So in general, the right heart cath should be the last part of the diagnostic workup until after everything was complete and you have a rough picture or like a good idea about what is the causative etiology of pulmonary hypertension. It should be done when the patient is stable, not in an acute setting, or not in a patient who are having like pneumonia or volume overload, because those things can basically make the interpretation more difficult. Patient should always be in an euvolemic state, and it should be done with no sedation or no supplemental oxygen as much as possible. There are not a lot of contraindications for right heart cath, but most important one is if you're suspecting right-sided endocarditis, because you don't want to mess around with a mobile vegetation and send it all the way to the pulmonary artery. If you have a mechanical tricuspid valve, which is a very rare thing to have these days, then that's another contraindication. So this is the Swan-Ganz catheter. It's a balloon-tipped catheter that helps the catheter to be floating, help it navigate through the pulmonary artery. And we talked about the different accesses that we can do these days to do a right heart catheterization. Usually the procedure takes about 5 to 10 minutes. This table has been recently published in the new guidelines that shows you the different pressures that we need to measure and their reference numbers, the normal reference numbers. So you can see we're measuring right atrial pressure, pulmonary artery systolic, diastolic, and mean pressure. And then we do a pulmonary artery wedge pressure. Then we calculate or measure cardiac output, measure the mixed venous saturation. And after that, based on these numbers, then we go and calculate a lot of different things, the most important of which is the pulmonary vascular resistance. This is an example of a waveform of a right atrium. And you can see basically here, the right atrium is about 11 or so, the mean right atrial pressure. It fluctuates. We have upper wave and lower wave, but the mean is around 11, which is higher than the normal, which is up to 5 or 6. So this is the first wave that we encountered when we do a right heart catheterization. Next is something like this, and this is an RV pressure waveform. So you can see that the systolic RV pressure here is up to 94, which is huge, which is a lot of RV pressure. normal RV pressure never exceeds 30 or 35. This is the pulmonary artery pressure waveform. And again, you can see here the systolic is reaching 93, almost systemic pressure. The diastolic is 33, and then the mean pulmonary artery pressure, which is what we use to make the diagnosis, in this case is around 53 or 54, this line around here. So this patient clearly has pulmonary hypertension. The question now, is it pre-capillary, the thing that we can treat, or post-capillary, the thing that we can only give Lasix? Depends on the wedge pressure, which is usually the next measurement. But in this case, wedge pressure was normal, so we know this is pulmonary arterial hypertension, pre-capillary pulmonary arterial hypertension. In addition to estimating or measuring the pressure, we do a shunt assessment to ensure that there is no evidence of congenital heart disease or left to right shunt. And we also assess cardiac output through different methods, either thermodilution or FIC method. And we use all of these information to, number one, make the diagnosis, and number two, also estimate the prognosis and the severity of the pulmonary hypertension. So basically, this summarizes the diagnostic workup of patient with pulmonary hypertension. With that, I would like to conclude and also like to welcome Dr. Shaya Shah. He's a dear friend of mine, a consultant pulmonologist and pulmonary hypertension specialist. And Dr. Shaya, the floor is yours for your next lecture. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. I'm trying to share my slides. So thank you, Dr. Hussam, Dr. Abdullah, and also Dr. Omar, who's coming after me. We are going already talked to Dr. Hussam and Dr. Abdullah about the pulmonary hypertension, the diagnosis, and also overview about the disease. My talk will be going to be about the pulmonary hypertension risk stratification and what does mean, and also to talk and speak about the pulmonary hypertension targeted therapy. It's a bit complicated. I'll try my best to simplify things for everybody. Before I start and talk about the pulmonary hypertension medication, I have to highlight and summarize some important things. So in order to wrap up some information that has been mentioned in the previous talks. So we have to keep in our mind that pulmonary hypertension is a group of diseases. It's mainly 5 diseases, and each one of, it's 5 groups, and each one of them has specific diseases. The most common causes of pulmonary hypertension is a group 2 pulmonary hypertension, that group 2 related to left heart disease, and the group 3, which is pulmonary hypertension related to lung diseases. And this is the most common causes of pulmonary hypertension. As mentioned before, this is called pulmonary hypertension, not pulmonary arterial hypertension. Why the 5 group is, why we have 5 groups? Because each one of them has different pathophysiology and have different treatment options. So the group 1, which is pulmonary arterial hypertension, is almost considered like 10% of all cases of pulmonary hypertension as a whole. And then we have a group 4, which is chronic thromboembolic pulmonary hypertension in general, or with some other similar diseases. And the group 5, where there is no specific pathophysiology can be considered, and the group of diseases that can cause pulmonary hypertension without clear underlying pathogenesis. So the most common causes is the group 2 and group 3. And these kind of disease, we have to treat the underlying cause, not to treat the pulmonary hypertension itself by a therapy. So the patient with group 1 is mainly, there is a problem at level of the vessels, and we need to treat them with a therapy. And group 4, there is a specific way of treatment that we are not gonna discuss it today. So pulmonary hypertension is an uncommon condition with limited awareness, with delay of diagnosis, as mentioned earlier by Dr. Hussam. This will lead to a decrease or delay in initiation of therapy. And this, as well as, will lead to potential clinical and worsening outcome and mortality in this group of patients. So the earlier diagnosis, the better outcome. So we have to keep in our mind that the mindset, the pathway, what generally we are doing in pulmonary hypertension in the clinic, how we are dealing with patients. Most of the time we are looking for the signs and symptoms. Sometimes we have some sort of screening tools that been used, and it has mentioned already by Dr. Abdullah, lead to think of underlying disease like pulmonary hypertension. So either we have some signs, symptoms told us this looks like pulmonary hypertension, or screening tools that told us this is pulmonary hypertension. This will lead to diagnostic test, which is right heart catheter. And after establishing the diagnosis of a group 1 pulmonary hypertension, we are going to stratify our patient. And the idea of risk stratification is to know exactly where is the patient. Is he at low risk, high risk, or intermediate risk of mortality, because each one of them has a specific way of aggressiveness of treatment. Then after that, we have to treat the patient, and based on the treatment, after a few or a period of time, we have to consider again to see, do we do something good for our patient? Are we under target of our goals or not? And then we have to re-stratify our patient, and it is my job today to discuss it with you. Stratification, treat, certification, again, adjust of treatment. So we have to keep in our mind that pulmonary hypertension patient, most of the time we see the patient at time of declining or decompensating. So the pulmonary vascular resistance is increasing with the time. The symptoms is getting worse and worse with the time, and pulmonary artery pressure goes down with the time, especially at time of decompensating, declining. So we cannot depend on pulmonary pressure itself to determine where is the patient. Most of the time we need further workup and studies to look for where is the patient exactly, like cardiac output, right heart catheter, pulmonary vascular resistance, and so on. In order to do this, we have to have like a good overview about our patient. We are not looking to the pressure by itself. We have to have like a comprehensive workup, comprehensive thoughts, comprehensive signs and symptoms to make sure where is the patient, and in order to add or adjust or keep the patient as it is. So we have to keep in our mind the important things that has mentioned earlier about the pulmonary hypertension groups. So the group 1, where there is a treatment for these kind of patients. So we have to start them in the targeted therapy that I'm going to talk about soon. The group 1 is called pulmonary arterial hypertension with underlying associated conditions, either idiopathic or associated condition. Group 2, it is a group where there is a pulmonary hypertension but caused by left heart disease. Group 3, where there's pulmonary hypertension caused by underlying disease of lungs, interstitial lung disease, COPD, or so, and so on. Group 3, where there is pulmonary artery obstruction, mainly chronic thromboembolic pulmonary hypertension. Group 5, there's a lot of diseases that no specific pathophysiology or etiology causing pulmonary hypertension will put it there. So let's start with the group 1, risk stratification. So earlier days, there is a lot of thoughts how we can manage or consider this kind or this patient of pulmonary hypertension as stable or improved or getting worse. So there's a lot of studies has been done in the past looking for this kind of thoughts or outcome. So they are looking for like a specific factor, like 6-minute walk test, and see, oh, okay, this patient has good 6-minute walk test. Most likely this patient is doing good. No need to change any kind of therapy. Unfortunately, this is not the idea. The patient with the time is getting worse and deteriorated, and progression of underlying disease and end of hospitalization and death. So there is a lot of thoughts how we can measure this kind of progression. So there is a lot of studies and registries looking for this kind of issues, like Revere Registry, Swedish Registry, Compera, or the French Registry. These registries looking for how we can measure the progression of the disease. And each one of them has a specific variable looking for the progression of the disease, and each of them has cons and pros in order to look for the progression and outcome of underlying disease. So what is the idea? Let's say, take an example of a French registry or French outcome. like this in 2017 has been published. When we are looking for like four strata or factor or criteria, when we approaching low risk factor in patient with pulmonary hypertension, when we starting them on therapy, and hit the low risk criteria, they have a good survival, a good outcome, and low mortality compared to the patient when they have no low risk factors or criteria. So our job always to be always aggressive in treating pulmonary hypertension, because we know by the studies, by the outcomes, that the patient, when they treated well, when be more aggressive, when they treat them earlier on with the double combination therapy, they have good outcome. So this is some of the calculators or risk scores has been published in the past, like in review registries or the 2015 EAC-ARS guidelines, looking for risk stratification and to know exactly where is your patient. We are not looking for one single factor. We have to look for multiple factors in order to reach the good overview about your case. So I will just skip these things. I will go to the 2020 guidelines when they publish the risk stratification and the guideline, AAC-ARS guidelines, and the guideline or the risk stratification looking for the risk of mortality at 1 year. Either if we are hitting like low risk group by like less than 5%, or high risk group when they reach like 20 or 25% of the patient presented at this red groups, or if they are at risk of or intermediate risk group. So all these criteria or strata looking for either clinical or imaging or invasive procedure in order to collect all this information for your patient, and then you can put or know whether you are doing a good or you need to add more therapy in pulmonary hypertension patient. So do we have a signs of heart failure? Do we have a progression of underlying disease, progression of underlying diseases? Do we have a syncope? What is the functional class? 6-minute walk test, cardiopulmonary exercise tests, biomarker like PNB or NT-proBNP, some of echocardiogram parameters, cardiac MR, and hemodynamics. So when we look for all these criteria, when we apply it on your patient at time of diagnosis and time of follow-up, you will get a good impression about your patient condition and whether he is improving in your treatment, or you need to add more therapy and consider advancing management. In the beginning, we are treating the patient based on the right heart catheter criteria. We diagnose the patient and confirm the diagnosis. We test the patient for vasoreactivity. If the patient is vasoreactive, we have to consider calcium channel blocker. If the patient is non-vasoreactive, we have to consider adding or starting pulmonary hypertension targeted therapy. So if the patient, I'd like not to confuse you by these things. However, if the patient has no comorbidity, meaning no cardiopulmonary comorbidities, and this isn't a recent guideline, we are applying the 3 risk stratification, which is this one. And once we apply it and see the patient at low or intermediate risk, we have to consider starting the patient in endothelin receptor antagonist and phosphodiesterase inhibitor therapy as a combined therapy upfront. And we have to see the patient after 3 to 6 months. If the patient at this risk stratification in the red zone, this means we have to consider starting initial therapy, including one of them should be IV or parenteral therapy with prostacyclins. And then we have to assess your patient after 3 to 6 months. After 3 to 6 months, we have to go back and re-stratify your patient and to see whether your patient is improved and hit the good criteria, or still the patient at risk criteria or strata. So we're applying the 4 strata as per the recent guideline for strata criteria or risk assessment. If the patient is still at low risk, we'll keep the same. If the patient at intermediate low, we have to consider something else. I will show you later on. If the patient at intermediate risk, we have to Also, a change in patient management. If the patient is still at high risk or he's progressing to the high risk, we have to consider something else. So we'll go back again to our algorithm. So our patient has been started in one of these things. We have to reassess your patient after 3 to 6 months, applying the 4 strata as mentioned earlier. And if the patient at low risk, will continue the same initial therapy, whether it is parenteral therapy or initial double combination therapy. If the patient at intermediate low risk, we have to consider either to add prostacyclin agonist, or we have to consider switching of phosphodiesterase inhibitors to guanylate cyclase stimulator. So we have 2 options at this at low intermediate risk. If the patient after 3 to 6 months he is at high risk or intermediate high risk, we have always to add therapy, including prostacyclin parenteral therapy. One important thing that we have to consider that when we have to consider a calcium channel blocker, and this is at the beginning of the diagnosis, we have done right heart catheter and the patient has positive vasoreactivity, and then you would like to start a treatment. You don't need to start if the patient at low risk, you don't need to start on pH targeted therapy. You can go ahead and start with calcium channel blocker. So what is the criteria? If the patient at right heart catheter and vasoreactivity test, he has like more than 10 millimeter mercury of drop in pulmonary mean pulmonary artery pressure from the baseline to less than 40 millimeter mercury with increase or any change in cardiac output, you have to consider calcium channel blocker. And I'm going to tell you what is the calcium channel blocker medication. After 3 to 6 months, you have to consider again to assess your patients. And if he is at low risk, continue the same. If he is at high risk, start pulmonary hypertension targeted therapy. So what is the tree of pulmonary hypertension therapies? In the older days, we have something called conventional pulmonary hypertension targeted therapy. Pulmonary hypertension therapy, as called that time, including like anticoagulation, calcium channel blocker, digoxin, oxygen, name it. And unfortunately, at that time, there is none of these therapy when they treat pulmonary hypertension make change in patient condition. In 1990, something like that, 94, 92, the first treatment has been approved, epoprostenol, for treating pulmonary hypertension. And then the cascade has been, alhamdulillah, Rabbil Alameen, started. There is targeted therapy and there's some supportive therapy. I'm going to talk about it in the next slide. So either we start patient in monotherapy in certain kind of patients. Most of the time we are using the double combined therapy as upfront. Sometimes we have to consider the triple therapy, and there is a study talking about this. I'm going to speak about it later on. What is the other options? After starting all of these, either we have to switch to something else or add something else. What is the end story? Advanced therapy and a transplant if the patient no improvement with all these kind of treatment, especially if he's at red zone or high risk group or stratifications. What is the general measures? In general, we are using pulmonary hypertension targeted therapy for group 1 pulmonary arterial hypertension. Sometimes we need to use some other measures that in order to improve the overall underlying conditions, like oxygen therapy. Not always we need oxygen, especially if there is like drop of hypoxia, especially in 6-minute walk test. We have to consider oxygen therapy. So not in all patients, but in certain kind of patients if they are hypoxic. Diuretics for Zomad and spironolactone as well. If there is recurrent right heart failure or the patient has recurrent lower limb swelling, you have to add it in the total management of pulmonary hypertension. Anticoagulation is not always necessarily in pulmonary hypertension. Actually, in some certain group of patients, like patient has antiphospholipid syndrome, and patient who has risk factor for like PE or DVT, patient has previous PE or DVTs using for other causes like atrial fibrillation or so on, but it's not used as a targeted therapy, it's not used as a primary therapy. We are not using anticoagulation as a primary treatment for pulmonary hypertension, so it just if needed. We have to restrict the salt and water to 1.5 liter a day or so. Exercise and rehabilitation is always important, but it should be under supervision. Avoid pregnancy and conceptions, because this is really important and increase in mortality in pulmonary hypertension. Some of lifestyle modifications and starting targeted therapy of pulmonary arterial hypertension. So in patient with pulmonary hypertension, is not just a start treatment and that's it. We have to think of multiple things like psychological support, spiritual support, rehabilitation, palliative care, follow-up and diagnostic therapies and medications and nursing, social support, and so on. So it's not the patient at the center of the treatment. He needs a couple of things, not just a targeted therapy of pulmonary hypertension. So let's start talking about the therapy. The therapy in pulmonary at level of fizzles, the pulmonary hypertension, there's imbalance between some neurohormones, hormones, enzymes that lead to more vasoconstriction, muscularization of underlying fizzles and muscles, and also hypertrophy and increased fibrosis. And this will lead to narrowing of underlying fizzles and decrease the blood flow, and this will lead to pulmonary increased pulmonary pressures. And this, by this, we have to consider what is the treatment that can revert or decrease or change the overall pathophysiology of underlying diseases. So we have three pathways. The first pathway called endothelin pathway. The second one is nitric oxide pathway. The third pathway is prostacyclin. Each one of them has a specific diseases is available in the market, alhamdulillah, available in the kingdom. Each one of them has a specific pathway and target. We are going to speak about it in this slide. So the first one, let us start talking about the nitric oxide pathway. We have to increase the nitric oxide in the pulmonary fizzles. If we increase it, this will lead to vasodilatation and decrease the proliferation of underlying pathological changes of the fizzles. So we have to increase it. How we can increase the nitric oxide? It's increased by two mainly ways. The first one is by inhibiting the phosphodiesterase inhibitors. So the nitric oxide attached to the body of guanylate cyclase stimulators. This will lead to change from GTB to cyclic GMB. When we have more cyclic GMB, this will lead to vasodilatation and proliferation. Cyclic GMB, it will degrade it later on by phosphodiesterase 5 to GMB again. And when we have a GMB, we have no effect on the blood vessels or or the at level of the fizzles. So we have to block the phosphodiesterase enzymes by giving sildenafil or tadalafil. The other way is to enhance the work of cyclic guanylate cyclase stimulators by giving riociguat, and I'm going to talk about it later on. When you increase the presence of cyclic GMB, this will lead to increase the vasodilatation and decrease the proliferation of the fizzles. So it's not just a vasodilatation, it's even decreasing the proliferation of underlying fizzles. The second pathway is the prostacyclin. Prostacyclin by arachidonic acid will change to prostacyclins, and prostacyclin by the receptors at level of the fizzles will lead to more enhancing or improving or increasing the ATP to cyclic AMB. And the cyclic AMB will increase the vasodilatation and decrease the proliferation. How we can do this? By enhancing the prostacyclin, by giving some medication like ibuprostanol, treprostinil, or Ilprost, or by prostacyclin IB receptor agonist, by increasing enhancing the IB receptors work. So this will increase the cyclic AMB. The third one is the endothelin 1 pathway. So the endothelin 1 will attach to endothelin A and B receptors at endothelium, and this will lead to vasoconstriction and proliferation. So when we inhibit the work of these receptors, this will increase or reverse the idea. So we'll have vasodilatation and decrease the proliferation. How we can do this? By giving macitentan, bosentan, or ambrisentan to block the receptors, and this will lead or inhibit the work of endothelin. So a lot of study, you can see all these study looking for the effect of this medication since 1990s. and to see the effect on the primary endpoint, like by 6-minute walk test or clinical failure, and to see whether this work or not. And this is actually work. So since 1990 to 2015, there's a lot of study, landmark studies, articles, work, see the effect of this medication and shows the improvement in patient with pulmonary hypertension. We're going to talk about it later on. So what is the medication available in the market right now? We have a lot of medication. The endothelin pathway, we have bosentan, ambrisentan, and macitentan. All of them is available in the kingdom, mainly the first and the last one. The nitric oxide pathway, sildenafil, tadalafil is always available. Ariosuguas cyclase, guanylate cyclase stimulator also are available. The third pathway is prostacyclin. We do have ibuprostanol. Treprostinil can come in two forms, IV or subQ. Elioprost came at a form of inhalation, and selexibag can come in at form of oral. So all these medication currently is used to treat pulmonary arterial hypertension. The first time in the guidelines, they mention all these medications with the doses and also the frequencies. So the ambrisentan, bosentan, macitentan, and all the other phosphodiesterase inhibitor and prostacyclin, and they mention how much you have to reach and what is the maximum dose of all these medication. And you can easily go back and review all these medications. So what is the initial dose and what's the maximum dose? The nitric oxide pathway, as I mentioned before, we have either to enhance the cyclic guanylate cyclase stimulators or to inhibit phosphodiesterase enzyme, and this will lead to improve the vasodilatation and decrease proliferations, or we have to work at level of the cyclic guanylate cyclase stimulators by Raysuguat. A lot of studies has been done in the past showing the improvement in patient condition by 6-minute walk test or decrease the clinical progression when we combine two therapy like Ambition or Compass. Endothelin receptors, as I mentioned, we have to block the receptors in order to improve the patient condition by decreasing the proliferation and improve the dilatation and decrease the proliferations. And a lot of study like Breathe One, Arise, Early, Ceraven, and Maestro, a lot of studies has been conducted in order to see the effect of these medication and the clinical outcome. There is also Breathe 2 and Ambition and Compass has been used combined therapy and see improvement in clinical outcome. Prostacyclin, again, we have to enhance and improve and increase the cyclic AMP in order to have like the effect. Either you need it like in simple or in details, that we have like prostacyclins working in a couple of receptors or cyclic IP receptors agonists like in selexibag. This will increase the cyclic AMP and this will lead to effect that we are looking for. A lot of studies has been used looking for the effect of ibuprostanol, Eliprost, either to the endpoint by 6-minute walk test or the survival and so on, or clinical failure. And this has been work in these kind of patients and pulmonary hypertension. Prostacyclin specifically has mainly 4 groups or 4 types: ibuprostanol, treprostinil, Elioprost, or selexibag. Each one of them has a specific administration or route. So ibuprostanil has been administered mainly through tunnels. So you have to put a PICC line or Hickman line mainly, and then you have to give the patient the pump, and the pump should continue giving the medication 24/7 all the year. The half-life of the treatment is like 5 to 6 minutes. So the effect is very fast. And unfortunately, the problem with the ibuprostanol is it has significant burden and needs special care. So the patient has to know how to mix the medications, how to use the cartridge, how to use the medication, the machine and device. You have to carry on all the time, the half-life of the therapy, and how we can change the cartridge all the time, like within 20 to 48 hours. And there is a risk of complication like rebound of pulmonary hypertension if they stop the medication within like a certain time period, like because of the short half-life or because of infection like CLABSI. Other important medication is treprostinil. It can mainly in two forms, like sub-Q or IV. It can be administered at level of sub-Q, and this may be the advantage of the therapy. The half-life is a bit better than the ibuprostanol IV. It is 4 hours half-life. It is light burden of care because of you can, if the patient has like a problem with the sites of administration, you can change from the abdomen, from right side to the left side, to the thigh, from right side to the left side, or to the shoulders. So the patient at home can adjust the site of administration therapy. The main issue of treprostinil is site pain, and is most common cause of stopping therapy in patients with pulmonary hypertension. The other form is ibuprost, as inhaled or breathed through a machine like INAB or other regular inhalation or nebulizer machine. To give specific dosing, it has to be used like from 4 to 6 to 9 times a day, because the half-life is 20 to 30 minutes. And this is the major problem of ibuprost. You have to use it multiple times a day. To some extent, the oral therapy like selexipag, it's need like titration dose. It's oral form. It need to start from 200 microgram and then to reach to 1,600 microgram to see the effect of the treatment. It is less potent compared to all other forms that I have mentioned of prostacyclin targeted therapy. All those, we have to assess the patient if there is any problem of using this kind of therapy. You cannot use ibuprostanol or treprostinil IV because of the machine. If the patient has like joint issues, intellectual issues, difficulty to reach healthcare system. So you have to always to consider a couple of things before starting therapy. The idea is not to start therapy. You have to consider that the patient is able to use this kind of therapy. Again, what is our goal? Why we need to, we understand the risk, we understand the therapy in general. So what is our goal? Our goal is to reach a certain outcome in our patient, to improve the patient, decrease the mortality, decrease the hospitalization, try to prevent patient to reach to transplant unless needed. So as I mentioned earlier, we have to stratify our patient. If the patient at low intermediate risk, we have to consider oral combination therapy by ERA or phosphodiesterase inhibitors. If the patient at high level or high risk, we have to consider adding prostacyclin therapy. We have to reassess your patient afterward applying for risk strata. After that, you have to consider all these kind of therapy, as I mentioned earlier. If the patient at low risk, continue the same medication that been on your patient. If the patient is intermediate low, you have to consider either starting selexipag or switching to raceguat. At intermediate high or high risk, you have always to consider parenteral therapy of prostacyclins and evaluate for lung transplantation. A lot of study has been done in the past looking for the outcome, mainly 6-minute walk test. Unfortunately, this is not reached to the significant change in patient overall mortality. So in 2015 ambition study, adding ambrisentan to tadalafil shows decrease in clinical failure by 50%. After that, all the clinical studies has coming after looking for the outcome of the patient, rather than looking for one single factor in order to know the patient improvement or progression of the disease. So adding double therapy shows improvement or decrease the clinical failure by 50%. Instead of a study, adding macitentan decrease the progression of underlying disease and hospitalization. Optima study, adding macitentan to tadalafil, significant improvement in hemodynamic and functional parameters in newly diagnosed patient of pulmonary arterial hypertension. So this is significant results. So because of that, we're adding always, we start always in double combination therapy in patient with no cardiopulmonary comorbidities and pulmonary arterial hypertension. GRAVE-1 trials and selexipag shows when adding to the baseline treatment shows reduction of clinical failure or deterioration by 30%. Another way of dealing with our patient, let's say we are in intermediate high risk, as I mentioned earlier, there is something called REPLACE trial, changing phosphodiesterase inhibitors to reyosiguat or guanidine cyclase inhibitors. This shows improvement in 6-minute walk test, improvement in biomarkers, improvement in functional class, and to some extent there is improvement in clinical or decrease the clinical worsening of pulmonary hypertension patients. One of the important things in the question, should we start, instead of starting 2 therapy, should we add 3 therapy? A Triton trial has been published in 2021. Actually, it doesn't show any improvement in pulmonary vascular resistance or hemodynamics, no improvement in 6-minute walk test or biomarker, but it does show improvement by 41% reduction of clinical progression, and this is the only positive things in these kind of patients. So a guideline is supporting what I have mentioned. We have always to start combined therapy as by the algorithm I have mentioned it earlier. And if there's no improvement, you have to escalate to adding therapy or switching, as mentioned before. Calcium channel blocker always has been considered in the patient with idiopathic heritable or drug-induced. At time of diagnosis, if the patient is vasoreactive, you have to consider calcium channel blocker, especially if there is improvement or reactive to nitric oxide study during right heart catheter. So a lot of things, a lot of studies, a lot of thoughts, ideas, and trying to find out another pathways. So tatarstat lately, a few days ago, has been approved. It looks like a new pathway of treating pulmonary hypertension. I think it will come the next few years, will be one of the targeted therapy everybody will know about. There's a lot of medications work in the pipelines. We'll see the effect maybe in the few years. A lot of studies, a lot of work in order to find out how we can improve the patient outcome of pulmonary hypertension. This is my talk. Thank you so much. For now, I would like to invite Dr.
Thank you, Dr. Shaya.
Go ahead.
Dr. Omar is stuck in the cath lab. He just contacted me. He will not be able to deliver his talk, but I will do the talk on his behalf. So I just, will you stop sharing your slides, Shaya? By the way, we have a significant number of questions from the audience that we will be very happy to address them and answer them after my quick presentation. And always we like to talk about cases, and truly this is what will solidify and make the, the theoretical part more interesting and exciting. So I'm going to go ahead and start with the first case. A young patient, 26-year-old woman, married with 3 children, presented to our emergency room with exertional dyspnea for about 4 years. That seems to be progressive in nature. She managed to have kids while she's having these symptoms, but also lately she has been having more symptoms, more chest pain, let's say 6 months before her presentation, 2 episodes of syncope. And you remember we talked about syncope is a bad thing. She was told that she's suspected to be having a pulmonary embolism during her 2nd pregnancy, and she was treated with a blood thinner at the time she was pregnant. And this is her X-ray when she presented to us. Nothing impressive. Her clear lung fields. You can pass this as a little bit of prominent of the pulmonary circulation, since we're talking about the pulmonary hypertension. Her ECG is bothersome. If you look into the lead 1 and 2, there is, and even 3, there is T wave inversion, asymmetrical, with a little bit of, these are signs of right ventricular strain. If you look at lead 2, there is very big P wave. Let me just increase the window here, and I think we can make it like more clear. So the P wave is a prominent, very large P wave, and there is signs of right ventricular strain or ischemia. And of course, with her history, recent pregnancy, somebody told her that she might be having a pulmonary embolism. We did a CT scan for her, and the CT scan was completely normal, with no, at least from the vascular side, there is no evidence of acute clots. The right ventricle that you see here, the white one, is much larger than the left ventricle, which indicates that there is dilatation of the right side. And I showed you a similar picture earlier where she did have pruning of the blood vessels in the circulation. We did the Dopplers of the lower extremity. Both of them were really compressing with pressure. So there is no evidence of deep vein thrombosis. Her blood workup was benign, nothing conclusive. Her BNP was elevated. At that time, we did the pro-BNP, and it was significantly elevated. Other workup is non-revealing. There is no evidence of liver disease. There is no kidney problems. Like her other lab is considered to be within normal. You remember schistosomiasis is one of the causes of PH. So we used to do a screening for schistosoma, and she did have it negative. The general screen for connective tissue disease was negative. We looked into the ANCA, we looked into other ANA, rheumatoid factor was negative, and like, you know, sometimes we check homocysteine levels, all were negative. HIV testing, just although she does not have the profile, just to take it out of our picture, it was negative. And like I said, her hypercoagulability, anticardiolipin was low. So she did not have significant you know, like a hypercoagulability state. This is her spirometry. And if you look into the spirometry, obviously this patient is having an asthma. There is significant improvement in her post-bronchodilator FEV1, almost normalizing. So this is a classical picture of asthma. She was never told that she has asthma before. So are her symptoms consistent with asthma? Is the like degree of her representation can be explained by asthma, at least partially so probably, but her even before bronchodilation, her FEV1 was considered to be pretty good. Yani it's not that low. We did 6-minute walk test for her, that's to assess her oxygenation and to assess her ability to walk. And she did walk 320 meters. For somebody who's 26 years old, this is considered to be low. And she did have a little bit of brief desaturation during the walk test that, like, you know, that picked up after getting some rest. With her history, again, we did the ventilation perfusion scan. This is her report of the lung perfusion scan. And obviously, it is abnormal. If you look at it, it is not homogeneous. There is plenty of defects in the, like, you know, the imaging. And it was considered, and it was reported actually to be abnormal. And this is her ventilation scan. Now, this is the ventilation scan, was considered to be okay. So the ventilation scan was passed to be like normal, and the perfusion scan was passed to be abnormal, and that was labeled as pulmonary embolism, suspicious of pulmonary embolism. So in this setting, I'm not gonna like have polls or votes. People might be thinking of this might be a CTEF case as per the you know, the presented. It's not looking like idiopathic. There are evidence of clots in the lung, and bronchial asthma should not explain the whole picture that she has. So what is our next step at that point? Shall we start treatment for CTEF? Shall we do any further workup, including like cardiac catheterization? Shall we send her somewhere else or consult somebody else? Now, when I reviewed her images, I was very bothered by the fact that this was labeled as a lung perfusion. Actually, this is a lung ventilation scan. So this is a lung ventilation, although the label was perfusion, and her lung ventilation is an actually perfusion scan. So they did mix up the images by mistake. Of course, this was a benign mistake, but it was reported as such because of the, like, you know, the abnormalities. I went back and then I looked at the parenchyma of the CT scan away from the blood vessels. And as you can see, there are some evidence of parenchymal disease that is consistent with probably like an active asthma. Small airway disease can give this picture with evidence of some air trapping here and there. So again, when we repeated the whole thing, since there was a question about this, we repeated another ventilation perfusion scan. Her perfusion scan was perfect, and her ventilation scan was abnormal, but improved after bronchodilators. After discovering her asthma, we treated her with good bronchodilation, inhaled steroids, and even when repeated the ventilation scan, things improved. Now, this is probably not going to move, but her echo was not benign at all. Her right side is dilated, and it shows features of pulmonary hypertension that is a little bit concerning, with evidence of tricuspid regurgitation. All of these features are consistent with significant pulmonary hypertension that is not because of a clot. Now, we established that her ventilation and perfusion scan are considered to be normal and should not be explaining it. Her estimated pulmonary artery pressure by an echo, it was about 62, which is considered to be high. Now, the jet velocity was 3.9. If you remember, we worry about 3.4 and above, or 34 millimeter and above. But in her case, it was significantly higher, and we cannot just sit there and do nothing. We have to proceed with doing a right heart catheterization. We did the right heart cath. Her right ventricular pressure was 89/4. You remember from my first lecture, I said the maximum upper limit of mean pulmonary artery pressure is 19, if you remember, and we call it pulmonary hypertension if it's above 20. PA pressure was 64. The right ventricular pressure is elevated, right atrial pressure elevated, pulmonary capillary pressure is normal, it's 10, less than 15. Her cardiac output is not bad, it's maintained, cardiac output 4.7. She was a little bit chubby, so her cardiac index was close to like 2.9 or so. So it should give her very good function, and her PVR is significantly elevated. We were talking about PVR of 2 and above being abnormal. So this patient has severe pulmonary hypertension. It is not because of a clot. It is not because of her asthma. Asthma does not cause this picture. And she normalized and improved with bronchodilation. What to do? The immediate next step that we do in this case, young female, she does look like idiopathic. We did not identify any features in her lab or a clinical presentation to indicate that she might be having a significant left heart disease, significant lung disease, and even rheumatological factors. So most likely this is an idiopathic form of pulmonary hypertension. The immediate next step in these cases, if you are in a center where you have good capacity, your people are aware of what to do, is shall we start her treatment? Shall we be happy with what we saw, and shall we proceed with later on? We normally do vasodilator testing for her. So this is her cath. If you look, I was covering the second part, post NO. Her pulmonary artery pressure significantly dropped to 31, almost half of it. And her capillary wedge pressure did not increase. Her cardiac output improved actually with this like a quick vasodilator testing, and her PVR significantly dropped down. So this is a unique form of pulmonary hypertension where we call it vasoreactive pulmonary hypertension. Have we not done this test, she will be labeled as pulmonary arterial hypertension, and she will require at least 2 double therapy upfront combination, as Dr. Shaya indicated earlier. So this is a unique form of pulmonary hypertension that responds to calcium channel blocker. So the definition of positive response, and we give NO. We have the patient inhale nitric oxide 40 up to between 20 and 40 parts per million in the cath lab, and we repeat the measurements after like 15 minutes or so. She should drop her PA pressure by more than 10 points, and the overall number should be below 40. And she did even do better than that. She dropped by 30 points, and her pressure went down to low 30. Normally, usually, and if they are really vasoreactive, they respond significantly and they become normal. So the treatment in this case, and this is a very unique, rare case, it's about less than 6% of pulmonary hypertension cases are vasoreactive, and half of them actually do respond to therapy on long term. We treat them with calcium channel blockers. Now, the common practice, cardiologists in particular, in the private, especially everywhere in the world, not only here, they will give anytime they see pulmonary hypertension by an echo or they suspect it, they will give a 5 milligram of amlodipine, and we are treating pulmonary hypertension. This is not a very good practice. These patients require very high dose of calcium channel blockers, whichever, or you can, and I like nifedipine. Most of my patients are on nifedipine, and this patient was on nifedipine. She was getting 120 BID. So this is an extremely large dose in order to maintain normality of the pulmonary artery pressure. And of course, some people might not tolerate this dose. Some people might not even benefit from this dose. Calcium channel blockers are negative inotropic drugs. Some patients, they might have a left heart disease. Some patients might be getting worse when you start them on calcium channel blocker therapy. Only and only after you perform and confirm the vasoreactivity, you can give calcium channel blockers for these cases. course, this is the patient we are talking about. Calcium channel blocker can give her gingival hypertrophy. She did have that, and with a little bit of support and encouragement, she continued the therapy. Things stabilized, and actually she did not need any further work on her dental from that regard. And she is like happy and doing very well only on calcium channel blocker therapy. We repeated some of the workup later on. Her cardiac size improved, PA pressure almost normalized by an echo, and the echocardiogram itself, if you look into the difference, there is a significant difference in the function and in the size of the ventricle by just giving calcium channel blocker. This is something that is, I just wanted to highlight this case because yes, it's rare, but it's so rewarding when you have a young person who have a somewhat fatal disease with lifelong therapy, progressive, and probably end up either being transplanted or dead at a young age. Now they are vasoreactive and they respond to a very cheap available therapy. They just need to be aware of their disease, not to stop it, because once the patients start feeling well, they tend to start skipping dosages, and that's not good. To maintain the normality of the PA pressure, they have to really be on high dose of calcium channel blocker. Every now and then we see cases that they lose this vasoreactivity, rarely so, but sometimes we keep an eye on them. Every now and then we check by an echo, and sometimes we repeat right heart cath to assure everything is going in a very well circumstances. I have another patient similar to this case that actually we allowed her to become pregnant, and she delivered normal vaginal delivery similar to any other regular woman, which is very, again, unusual circumstance when we deal with pulmonary hypertension. Another quick case that I wanted to share with you that we did not discuss much is another young woman. Our patients are young and women. She's obese. She did suffer from recurrent pulmonary emboli, over the last 3 years recurrence. She's on warfarin. Her INR is usually therapeutic. She never had a workup for hypercoagulability when she presented to us. There was never a diagnosis of DVT that was proven by an ultrasound. She came in with basically very respiratory distress, progressive dyspnea, and to the point where she's almost decompensating. She was tachycardic, tachypneic, borderline oxygen saturation. Her exams were clear, very loud P2, and she did have significant lower extremity edema. And this is her X-ray upon presentation. So this is a woman who has recurrent pulmonary emboli, who comes in with decompensated state. Her cardiac shadow on the X-ray is large, and there is a prominence of the pulmonary artery. So life is easy. We always suspect pulmonary embolism or related complication of pulmonary embolism. In these cases, the artery is much larger than the aorta, and this is a good sign that there is a significant dilatation of the pulmonary circulation. We did not see intraluminal clots, but if you look into the pulmonary arteries themselves, there are some what we call web. This is web as an indicator of a healed or trying to heal clot in that region, but it was not very completely recanalized, leaving a scar inside the blood vessel. And if you look closer, this is what I'm talking about. This is a web. And if you look into the mediastinum, there were dilatation of the mediastinal blood vessels to compensate for the blockage that is taking place in in the pulmonary circulation. Her echo shows severely dilated right ventricle, and there is significant air trapping, not air trapping, we call it mosaic perfusion pattern, where the dark areas actually they are under perfused because of the pulmonary embolism. And this is her echo upon presentation. Let me show it again. And her PA pressure was significant by an echo. So the echo was very bad, much dilated right side. The function is reduced and estimated the pressure in the 90s. We did complete workup. It was completely almost negative. There is nothing that can indicate any problems. Her thyroid function is normal. Her immune status is negative. There is no HIV. There is no rheumatological diseases. We did all the workup. She had the anti-cardiolipin antibodies were positive, the IgG form, and she is hypercoagulable as expected. She does fit the profile for it. VQ scan is extremely abnormal, and this time this is a true perfusion, not an error, where almost there is no perfusion to the left lung, and this is something that we commonly see in these cases. So this is very positive ventilation scan. Pulmonary function test, we did spirometry for her. It's acceptable. There is no airway obstruction. It's not completely normal, but it is not like this is from pH, not necessarily to be related to another airway disease or interstitial lung disease. Her 6-minute walk test upon presentation was horrible. She only walked 162 meters in 6 minutes. And in this test, we asked the patients to walk on their own pace for 6 minutes. Probably if you walk 6 minutes and you are perfectly well, you will walk probably like, 1,000 meters easily. And young people might do more. And we don't ask them to run. Just keep walking for 6 minutes. She only did 162 meters. 162 meters is nothing after encouragement, and she has to stop. And if you look at the oxygen saturation, it dropped down to the 84, and she did require oxygen during the test. So this is something that is not good. She's obese. We always say lung diseases, sleep apnea, obesity, hypoventilation can contribute to pulmonary hypertension. I did a sleep study for her, and it was negative. She did not have pulmonary, like she did not have sleep apnea or obesity hypoventilation syndrome. We did the right heart cath as expected, and the pressures were extremely high, 108 over 34 with a mean pressure of 55. So the pulmonary artery pressure mean is 55. There is a discrepancy between the systolic and diastolic, and this is classical when we have proximal obstruction. Wedge pressure was normal, and cardiac output is considered to be low. What shall we do at that point? That was many years ago. At the time, medical therapy was started. She was started with sildenafil. Then she was added bosentan. At the time, that was the available ERA. And then they added inhaled iloprost for her in a sequential manner. So she, like when I start taking care of her, she is on double therapy. I added the triple therapy, and I immediately referred her to surgery. Back then, we did not have any surgical interventions to be done in Saudi Arabia, so we did send her to San Diego, where I normally send her. On medical therapy, she somewhat improved. Her minute walk test improved to 180 meters, not that much, but clinically, she felt a little bit better, but she's on 3 agents. That is to support her pulmonary vasodilatation. Upon referral to San Diego, we repeated VQ scan, confirming the earlier findings. There is no new clots, and it continues to have problems. She went to San Diego, alhamdulillah. Luckily, she did make it to the surgery. She had surgery, and this is her actual specimen. This is what came out of her lungs after surgery. She did well after surgery. She stabilized over there, no complications, came back to Saudi Arabia. We did VQ scan just to see what is happening. Perfusion to the bad lung was somewhat improved relative to the previously, and the patient did manage to walk almost 300. Remember, she's morbidly obese, so there is improvement by all means. We stopped all the therapy. This is her echo after surgery. So when she came back to Saudi Arabia, I did an echo for her. Her PA pressure is difficult to really estimate. It's within normal, and her right side is barely, you can see it, with very good left-sided function. She did beautiful. This is the expected course till this point for these patients who have surgeries. The story does not end there. 2 years later, she presented with fatigue and dyspnea and shortness of breath. We continue to follow these patients, although they normalized at one point. The only treatment, she was on anticoagulation with warfarin, since she is an anticardiolipin patient, and we worked her up again. Her minute walk test dropped down to 177. There is evidence of oxygen desaturation. Pro-BNP was increasing progressively after being normal, and this is her new echo. I was very disappointed to see pictures similar to the pre-surgery numbers. She does have pulmonary hypertension that is significant. So we looked into VQ scan. Her VQ scan is her best. And even relative to the one immediately after surgery, it was great. We did not identify any recurrence of her disease. We did another right heart cath for her, and her mean PA pressure was 61 millimeter mercury, which is significant. Her wedge pressure is normal, and of course, her PVR was high. Now, normally, we don't need to do vasodilator testing for these patients. We know they are not going to get benefit. It was done for this patient, and it did not show significant improvement as expected. But it was done probably by a protocol at that time that was done. So we always worry about BMPR2. Is that an idiopathic form of pulmonary hypertension that just happened to coexist with CTEPH? We did send the genetic mutation, and it was negative. So at that time, riociguat was available to treat patients specifically who have residual or recurrence of their pulmonary hypertension after pulmonary end arterectomy. So she did the surgery. She did not have any targets to go after repeat surgery. At that time, probably there was no balloon. And of course, we managed to get her medical therapy, like a little bit of side effects, but improved quickly. Pro-BNP improved significantly. Her continued to desaturate to 85, but her 6-minute walk test improved with, over time. Now, she never became normal. We had to add macitentan for her, which is off-label. Usually, this is not approved indication for chronic thromboembolic pulmonary hypertension, but we felt that we wanted to improve her overall functional status. We added the second therapy for her. True enough, her minute walk test improved 200 something on double therapy. On medical treatment, her echo improved with double therapy, but she continues to not do very well. The obesity in part, but at least from pulmonary hypertension point of view, she did better on medical therapy. We don't have much other options. I recently checked with her if she's a candidate for balloon end arterectomy, which is another procedure that we inflate the balloon inside the pulmonary circulation and open up some of the closed channels. Unfortunately, her disease is distal, and she will just be treated and behave similar to the pulmonary arterial hypertension. I thought since we did not talk much about these two areas of the pulmonary hypertension, I'll show you cases that are real life from our clinic with real x-rays and images that will give you probably a better understanding of what is it that we are talking about. We will open the floor to answering some questions. Actually, we received significant number of questions. I'll answer some of them quickly, and I'll ask my colleagues to please join me in answering the questions that were brought up. Very interesting questions, and obviously the audience were having different backgrounds in their medical practice. There was a question about the mode of inheritance. I mentioned that this disease, sometimes if it's heritable, mode of inheritance, this is an autosomal dominant with incomplete penetrance, meaning that it does not necessarily to happen, but if it happens, it will happen at a younger age, meaning a mother who is in her 40s, for example, she develops pulmonary hypertension, her daughter, if she is going to develop, and the probability here is about 25%, that she will develop it at a younger age group. And this is a very aggressive form. We have 2 patients in my clinic with heritable disease. Some groups are really collecting these cases because they tend to treat them more aggressively and they do more testing for them. We mentioned BMBR2, but there's other genes that are associated with this. The mode of inheritance is autosomal dominant. One question was about life expectancy. We mentioned that it's a bad and progressive disease. Without any therapy, 2.8 is the median 3-year survival in the original data. So imagine patients who are with pulmonary hypertension, let's say 36, 35 years old woman, and there is a 50% chance that she will die within like less than 3 years. This is considered very significant. Now with therapy, things has improved, but the functional status still plays a role. The median survival of patients who present with functional class 4, meaning that they came with decompensated right heart failure, can only be 6 months, and this is without very aggressive therapy. Alhamdulillah, we are doing better than that. We always see cases who come and decompensate, but we treat them aggressively. We send them home, and some of them are still alive after many years, but that's at least what is reported in the literature. Now, I don't know if it's Abdullah with us, but I can ask Shaya. There was a question about a case that people come to the emergency room, the patient will get lost between cardiology or pulmonary, the cardiology will end up admitting the patient or taking care of the patient, and like they don't get effective therapy early on. So who to treat this disease, Shaya?
Thank you, Dr. Hussam. Thank you for attendees. So, and generally, this is always happen in different hospitals where there is no pulmonary hypertension expert in the around. So sometimes we'll be confused between which team should take care of. I think this patient should go to the most appropriate expert in the field in this kind of center or hospital. Difficult to answer even in our center. Sometimes we face some difficulty with some people who's thought this patient should go to so and so. In general, I think when you have a patient with pulmonary hypertension and you're stuck on, just refer to nearest center with pulmonary hypertension. We are more than happy to accept any cases from anybody in the kingdom. just refer to us. We are more than happy to take over, especially if the group 1 pulmonary hypertension or group 4 pulmonary hypertension that need a specific targeted therapy. Sometimes we accept cases with like group 2 just to make sure there's a group 2 that you need to treat. So either you refer to centers with pulmonary hypertension, or maybe you need to discuss directly with the people that covering these kind of cases in your center.
Thank you, Shaya. Another interesting case that was presented actually briefly, not enough information, but 80-year-old presented with by echo. PA pressure estimation is about 50. Patient is having significant lower extremity edema and ascites. It looks like there is some liver disease. Left heart is normal by physical exam, and by echo, the left-sided ejection fraction is normal. So they are wondering, what shall we do at this point? Of course, you have to see the images, you have to see the patient, but at a pressure of 50, it's unlikely to be like in significant pulmonary hypertension. By echo, a pressure of 50 systolic, that does not translate much into mean pulmonary pressure. And the echo is not accurate. As Dr. Abdullah mentioned, that you have to really have a proper test by doing the right heart cath. From the significant ascites, from significant lower extremity edema, it looks like there might be a primary liver issue here that we are dealing with, that we have to consider before doing anything else. Even if we do the cath for her, if you have facilities that will really make life easy, but diuresis, I think this is the first step to do. Keep looking for an underlying cause for this. And like Dr. Shaya said, we are like, our eligibility is accepting any kind of patient. Now we are accepting even life-threatening who are not eligible to be treated at the Ministry of Health centers. So if you feel like the patient needs to be referred to a center of excellence, just go ahead and send the referral. We'll be very happy to help if we can. Another case that was probably from a pediatric person about pulmonary hypertension in the setting of pulmonary stenosis. This is very interesting. I have a patient. I'll tell you the story. She's young, female, in her like 20s, came in with symptoms of shortness of breath. She's seen a private cardiologist, did an echo. She has pulmonary hypertension by the echo. She was given sildenafil, did not improve much. She was given bosentan. She came to us with significant shortness of breath. And what did she have? She had pulmonary stenosis. Pulmonary stenosis does not equal pulmonary hypertension. The echo picture can look exactly the same as pulmonary hypertension, but the cause of the dilatation of the right side is the stenotic pulmonary valve. And alhamdulillah, we have interventional cardiologist, like he just managed to put a balloon. Once he passed the catheter beyond the pulmonary, pulmonary valve, the pressures were normal, as expected. So the diagnosis was clear. A couple of balloons into the, I see her every year, and she is doing beautiful off therapy. She did not need to be treated to begin with. That's why following good diagnostic workup, think about the patient, is probably the key to proper diagnosis and proper treating these patients. There was a question about cases of emergency. Now, I think I can handle this one. Patients who have pulmonary hypertension who come to the emergency room, they are very delicate group of patients. Sometimes they present with decompensation, and we have to escalate therapy. The management has to be very closely run by a PH expert, individual and center. They cannot just run it in the emergency room. Everybody comes to the emergency room. They are going to be given fluids, and they are going to be given some antibiotics and some diagnostic workup that might not always be necessary. So we do always recommend is checking with somebody who can handle these cases. Parenteral therapy is important in these cases because it might save lives. You have to have availability and expertise in the use. Now, patients who are not known to have pulmonary hypertension and they come to the emergency room or to the ICU for a reason or another, you have to be careful. Again, the person who's going to establish that diagnosis or the suspicious diagnosis has to be at least experienced in dealing with them, and we can always establish the diagnosis later on. If we really think this is pulmonary hypertension, you can start therapy with whatever is available, and later on we can confirm and stop, adjust, and modify the therapy as such. Very complicated case, question, and we do see this commonly at King Fahd Medical City. I suspect the large centers as well. I gave a talk about this issue to one of the international conferences, and the topic is very hot. and it's very vague for the non-practitioners in the ICU. So I do ICU, I see them in the ICU, and again, this is an area of a little bit limited experience, but we are always happy to share our knowledge, our experience in this field, but this is a little bit subspecialized area of care in general. Now, there is a question about, I'll ask Shaya, and how we are about to start Ramadan. كل عام وأنتم بخير, تقبل الله طاعتكم. Somebody is asking about fasting in Ramadan with patients with pulmonary hypertension. Shaya?
Thank you, Dr. Hassan. So in general, there is no issue with fasting Ramadan in pulmonary hypertension therapy patients, especially if they adjust their therapy to, like, there's some medication can be used once daily. So we can adjust this kind of medication to use this kind of doses and frequencies. However, some kind of cases that depend on preload, afterload, depend on how much of fluid they are taking before and after. Sometimes they are working and they lost a lot of sweats and something like that, so they cannot do it to the Maghrib. So actually, it's judgmental from patient to the patient. You have to consider it, to ask patient if they cannot tolerate like fasting, especially if there's progression of the symptoms. If they cannot tolerate the adjustment of the treatment, you have to tell them you cannot be a fast. However, we have a good number of our patients, they are fasting in Ramadan.
Very good. Another question about travel, same thing. We don't prevent them from traveling. They can travel. Usually they don't have hypoxia issue. They have to be just careful. And if in doubt, we can always do the flight simulation test to assure that. But in general, they can fly by the airplane. There was a question about very, very smart question, at least in my view. What's the relationship between uric acid and pulmonary hypertension? This is a deep question. We used to check uric acid in pulmonary hypertension patients as an indicator of inflammation or overall well-being. The higher the uric acid, the more likelihood that the patient are not going to have very good prognosis. And actually, it was one of the if you wish, parameters that we checked early on, and there are studies to support that. So it's a general thing that people don't do very well when their uric acid is very high. I will like some other questions that I cannot handle. Unfortunately, people were asking about exact pressure by echo in neonates. Dr. Omar Tamimi is not with us. He could have answered that one. I'm not sure if Abdullah has idea about the estimated pressures in neonatal echo. But I will go to the most important question that we received, and I will finish the activity with is a patient who had an echocardiogram and the echo showed positive for pulmonary hypertension. Do we refer them all to right heart cath? The quick answer is no, and the proper answer is all what we talked about during this 2-hour activity. Patients has to be stratified according to the pre-tested probability. If you have a patient who is clinically in heart failure, their echo will show pulmonary hypertension. So you know that you're dealing with a group 2 pulmonary hypertension. If the patient is having very advanced interstitial lung disease, you know that their PA pressure will be elevated. If the patient is having borderline blood pressure elevation in the echo, you have to look into other factors. You really worth subjecting them to the risk of the cath, although we learned that the risk is not much. But always, when in doubt, you can do the right heart cath. Is it really going to be feasible to do it on everybody? The answer is no. So you do it immediately, as soon as you can, whenever that this patient might have a pulmonary arterial hypertension. If that question came to your mind because of age, because of the overall clinical picture, immediately refer to the right heart cath. But if you have a reason to explain the changes by the echo, you really don't have to do right heart cath for everyone. I tend to be conservative in that regard, and I will really sit with the patient. I will look into them clinically, and sometimes I just monitor them and confirm that this is not a PAH-related change in the echo. And sometimes seeing is better than reading a report. So with experience, you can really look at the echo and suspect now this is not that serious. Echocardiogram can change by the day, or sometimes in ICU, from our experience, by the hour. Changes in the fluid status of the individual might make changes in the in the picture. And similar to this idea, there was another question about a patient with pulmonary embolism, and they do not have right-sided changes by an echo. That means their pulmonary embolism is not probably serious. Now, classification of pulmonary embolism, it depends on the risk of deterioration, and patients who are intermediate or high risk, they usually are associated with right ventricular dysfunction, as indicated by elevation in the pressure. And sometimes, usually, the pressure is not that high, by the way. And if you look into all the studies that were done, invasive right heart cath during a PE, the pressure does not exceed like 40. Lots of times it's upper 20 and in the 30s, because the ventricle is unable to generate pressure higher than that. Otherwise, it will get stunned and the patient will really become hypotensive and having serious, significant, life-threatening pulmonary embolism that requires thrombolytics. So in general, this is a risk stratifying model that if the changes on the echo are there, that means the patient is at a higher risk of developing complications from his PE and probably requires monitoring plus minus thrombolytics or catheter directed. It depends on the center. So yes, it is acceptable not to have changes on the right ventricle. And if there are changes, you have to monitor them, because usually they resolve, and most of the time, almost all the cases, they will resolve to normal. The ones who don't resolve to normal, these are the ones that you probably would want to keep an eye on them, and usually they will have symptoms suggestive of some problem. You know, they are continuing to have shortness of breath or chest pain or like dyspnea upon exertion and limitation in their function. Screening for pulmonary hypertension after acute pulmonary embolism is not recommended. Studies were done and it's useless. You're not going to pick these few cases. But once you start thinking, this patient had a pulmonary embolism a year ago and now he's having significant shortness of breath, you have to rule out CTEPH, because the time frame of developing CTEPH after acute pulmonary embolism is within 2 years. So when we put all things together, I think it can be fitting in place. Now we are 9 minutes after schedule. We thank you all for joining us. We have 3,062 attendees, and I have been looking at this number. It did not drop from the 3,000. Hopefully it was beneficial to all of you. We enjoyed the activity. We thank the sponsor for sponsoring this activity, and we are, all of us, teams at KFMC, from individuals practicing in PH or as a referring center for PH. We are here to help and serve all the community with whatever needs, even just for evaluation. Reach out to us. Now we are here to answer all your questions, and wishing you a pleasant rest of the night, and Ramadan Mubarak على الجميع وكل عام وأنتم بخير. شايع.
Thank you so much. Thank you for attendees. Thank you, Dr. Hussam. Thank you for the sponsor by Bayer. Really, we are so grateful to be with us with you today. And again, as mentioned by Dr. Hussam, we are more than welcome to accept any referrals. We are more than happy, more than grateful to send actually patients. We are, alhamdulillah, capable to have all the workup, diagnostic procedures, and also the treatment. Our job is to serve this kind of patient who's unfortunately came late to the or presenting late in pulmonary hypertension. So we appreciate your cooperation for this kind of cases. And thank you again.
Thank you all. Thank you. Have a good night.